In the clinical world, few things arrive with the same urgency as an arterial blood gas result. For many healthcare professionals, nurses, respiratory therapists, students, that slip of paper or notification on a screen can feel like a code blue for your brain. The numbers stare back at you. pH, PaO₂, PaO₂, HCO3. They demand immediate interpretation and decisive action. Panic can easily set in. You know this information is vital. It holds the key to understanding your patient's acid-base balance. It also reveals their oxygenation status. It can be the difference between intervening correctly and missing a critical turn in their condition. The pressure to get it right and to do it quickly is immense. This feeling of being overwhelmed is incredibly common. The traditional methods of teaching ABGs often involve complex charts and confusing arrows. That academic approach doesn't translate well to a busy hospital floor. When a patient is struggling to breathe or is hemodynamically unstable, you don't have time to consult a textbook. You need a reliable, repeatable system you can execute under pressure. You need a mental framework that cuts through the noise and delivers a clear answer. This is not just about passing an exam. It's about building the confidence to act when your patient needs you most. We need to change the way we approach ABGs. Move away from panic and toward a process. Imagine a method so ingrained that interpreting those numbers becomes second nature, as automatic as taking a pulse. That is the goal of our time together today. We are going to demystify the arterial blood gas. We will provide a straightforward, four-step method that works every single time. This is for the nursing student cramming for an exam, the new graduate on their first night shift, the seasoned respiratory therapist looking for a clear way to teach others. Over the next 22 minutes, we will build a new foundation for your clinical practice. We will replace anxiety with calm control. This is not about memorizing dozens of exceptions or esoteric formulas. It is about understanding core principles in an intuitive, clinically practical way. We will use simple mnemonics, clear visual aids, real-world case studies to solidify your understanding. By the end, you will not just know how to interpret an ABG, you will understand what it means for your patient and what you need to do next. Our journey today is built on a simple promise. We will equip you with a calm, clear, and clinical four-step method to master ABG interpretation. We will start by checking the pH, the first and most important clue. Then, we will use the simple yet powerful Rome mnemonic, Respiratory Opposite Metabolic Equal, to quickly identify the primary problem. This is the cornerstone of our diagnostic process, allowing you to pinpoint whether the lungs or the kidneys are the source of the imbalance. We will make this concept tangible with clean animations that show you exactly how the arrows line up, removing any guesswork from the equation. Next, we will introduce a tool that will revolutionize your approach to compensation: the tic-tac-toe grid. This visual method is incredibly effective for determining if the body is trying to correct the imbalance and to what degree. We will walk through how to set up the grid and how to place the values, watching as the pattern reveals whether the problem is uncompensated, partially compensated, or fully compensated. This step is crucial for understanding the chronicity of a condition, like the difference between an acute asthma attack and long-standing COPD. After we have mastered the acid-base component, we will move to the final, critical step, evaluating oxygenation. We will look at the PaO₂ and SaO₂ to understand how well the patient is getting oxygen into their blood. This is where the numbers on the page connect directly to the patient in the bed. We will explore what these values tell us about the different types of respiratory failure, helping you to decide on the most appropriate interventions, from applying a nasal cannula to preparing for mechanical ventilation. Our promise is that by the conclusion of this session, you will be able to interpret any ABG with newfound confidence. The panic will be replaced by a methodical process, and confusion will give way to clarity. You will be able to take that piece of paper, run through the 4 steps, and confidently articulate the patient's status and the required clinical actions. You will be faster, more accurate, and ultimately, a more effective and assured healthcare provider. Let's begin. Our journey begins with the first and most fundamental step, looking at the pH. Before you glance at any other number on that report, Your eyes must go directly to the pH. This single value is your compass. It tells you the overall direction of the patient's acid-base status. The normal pH of human blood is tightly controlled within a very narrow range, 7.35 to 7.45. Think of this range as the safe zone, the physiological balance point where our cells and enzymes function optimally. Your first action is simple. Compare the patient's pH to this normal range. Normal pH is between 7.35 to 7.45. Ask yourself, is it higher or lower, or is it sitting comfortably within that normal window? This initial assessment is a binary choice, a simple fork in the road. It prevents you from getting lost in the other numbers prematurely. By focusing on the pH first, you establish a clear starting point. This methodical habit prevents the cognitive overload that often leads to panic. It is a moment of grounding, a deliberate action that says, I am in control of this process. A low pH below 7.35 indicates that the blood is more acidic than normal, acidosis. A high above 7.45 pH signifies that the blood is more alkaline, alkalosis. If the pH is within the normal range, it could mean the patient has a normal acid-base balance, or it could indicate a fully compensated disorder, a detail we will explore later. For now, the mission is just to determine which side of 7.4, the absolute midpoint of normal, the pH falls on. This disciplined first step is the bedrock of calm interpretation. It acts as an anchor in a potential sea of confusing data. By making check the pH first a non-negotiable rule, you create a repeatable mental pathway, bringing clarity to a critical piece of clinical data. Once you have determined whether the patient is in acidosis or alkalosis by looking at the pH, it is time for step 2, identifying the primary cause. Is this a respiratory problem or a metabolic problem? To answer this, we use a mnemonic: ROME. ROME, respiratory opposite, metabolic equal. This phrase links pH to two ABG values, PaO₂ and HCO3. It pinpoints the system at fault: respiratory system or renal metabolic system. PaO₂, partial pressure of carbon dioxide, is the respiratory component. Carbon dioxide dissolved in blood acts as an acid. PaO₂ is controlled by the lungs through ventilation. Normal PaO₂, 35 to 45 millimeters of mercury. HCO3, bicarbonate, is a base. Bicarbonate is regulated by the kidneys. HCO3 is the key metabolic component. Normal HCO3, 22 to 26 milliequivalents per liter. Apply ROME. Respiratory opposite. pH and PaO₂ move opposite. Respiratory primary. Example: low pH and high PaO₂, respiratory acidosis. Example: high pH and low PaO₂, respiratory alkalosis. Metabolic equal. pH and HCO3 move the same way. Metabolic primary. Example: low pH and low HCO3. Metabolic acidosis, loss of base or acid gain. Example: high pH and high HCO3. Metabolic alkalosis, excess bicarbonate.
Let's put ROME into practice with a clear example to make this concept stick. Imagine your patient's ABG results come back. The pH is 7.25, the PaO₂ is 55 millimeters of mercury, and the HCO3 is 24 milliequivalents per liter. First, you look at the pH. At 7.25, it is low, so we have acidosis. Now we use ROME to find the cause. Let's compare the pH to the PaO₂. The pH is low, and the PaO₂ of 55 is high. Normal is 35 to 45. They are moving in opposite directions. This fits the respiratory opposite rule, pointing squarely to a respiratory acidosis. The high CO2 is the acid causing the low pH. The HCO3 at 24 is normal, confirming it is not the primary driver. Let's try another one. Your next patient has a pH of 7.52, a PaO₂ of 40 millimeters of mercury, and an HCO3- of 30 milliequivalents per liter. Step 1. The pH of 7.52 is high, so we have alkalosis. Now for step 2, we apply ROME. Let's check the metabolic component first this time. The pH is high, and the HCO3 of 30 is also high. Normal is 22 to 26. They are moving in the same or equal direction. This perfectly matches our metabolic equal rule. Therefore, the primary disorder is a metabolic alkalosis. The PaO₂ of 40 is normal, which further supports our conclusion that the problem is not respiratory in nature.
However, you will often find that both the PaO₂ and the HCO3- are abnormal. This is where a common point of confusion arises, but it shouldn't. This situation usually indicates that compensation is occurring, which is the topic of our next step. A pro tip for when you are just starting out. Write the values down and literally draw arrows next to them. Write the pH, then draw an arrow up or down to indicate if it is high or low. Do the same for the PaO₂ and the HCO3-. This simple visual trick makes the opposite or equal relationship immediately obvious. It takes the abstract nature of the Rome mnemonic and turns it into a concrete, visual tool. This practice builds muscle memory, and soon you will be able to see these patterns in your head without needing to write anything down, moving you one step closer to effortless interpretation. We have now successfully identified the primary acid-base disorder using the pH and the Rome mnemonic. But the body is a dynamic system. It rarely allows an imbalance to go unchallenged. This brings us to step 3. Assessing compensation. This is where we determine if the body is trying to correct the problem and how effective that effort has been. To do this, we are going to use an incredibly powerful and intuitive visual tool, the tic-tac-toe grid. This method transforms the abstract concept of compensation into a simple, visual game, removing nearly all the complexity and making the answer immediately apparent. Compensation is the physiological response from the system that is not causing the primary problem. If the lungs are the source of the acidosis, respiratory acidosis, the kidneys, the metabolic system will respond by retaining bicarbonate, a base, to try and bring the pH back toward normal. Conversely, if a metabolic problem is causing the imbalance, the lungs will attempt to compensate by adjusting the rate and depth of breathing to either blow off carbon dioxide or retain carbon dioxide, an acid. The tic-tac-toe grid is the perfect tool to visualize this interplay. By simply placing each of our 3 key values, pH, PaO₂, HCO3-, into the correct box on the grid based on whether they are acidic, normal, or alkaline, a pattern will emerge. This pattern will spell out the complete acid-base story, the primary problem, and the state of compensation. It is a foolproof way to ensure you are interpreting the relationship between all 3 variables correctly, every single time. Setting up your tic-tac-toe grid is a simple and repeatable process. First, draw a standard hashtag or pound sign to create your 9 squares. Next, label the 3 columns. Leftmost column, acid. Middle column, normal. Rightmost column, base or alkalosis. To do this, you must know their normal ranges. Normal pH is 7.35 to 7.45. PaO₂ is an acid. High, greater than 45, is acidic. Low, less than 35, is basic. This inverted relationship can be tricky, but the grid simplifies it. HCO3- is a base. Low, less than 22, is acidic. High, greater than 26, is basic. Let's walk through placing the values. If your patient's pH is 7.25, it is low, so write pH in the acid column. If their PaO₂ is 60, it is high acidic, so write PaO₂ in the acid column as well. Finally, if their HCO3- is 28, that is high basic, so write HCO3- in the base column. That is all there is to it. You are not performing any calculations. You are simply sorting the values. The act of placing the numbers transforms them from a confusing list into a meaningful pattern. Look for a line of 3. Find which value shares the column with pH. PaO₂ with pH, VC's respiratory problem, HCO3- with pH, Jaeger's metabolic problem. Now, assessing compensation. 2 values in 1 column, plus third alone in normal. Uncompensated. The body hasn't started to correct it. Seen in acute or sudden problems. Most common, partial compensation. one value in each column. The pH is still abnormal, but the opposing system has started to make a corrective effort. The body fighting back, but not victorious yet. If pH is normal, full compensation. The compensatory response has been successful in returning the pH to the normal range. This is usually seen in chronic conditions. Pro tip: check if the normal pH is on the acid side, less than 7.40, or base side, greater than 7.40, to deduce the original primary problem. We have now mastered the 3 steps to decode our patient's acid-base status. But the ABG report gives us another critical piece of information we must not overlook. This brings us to our 4th and final step: evaluating oxygenation. It asks a more fundamental question. Is the patient getting enough oxygen into their blood?
Hi, I'm Dina, a respiratory therapist. And this is where we look at PaO₂, the partial pressure of oxygen in arterial blood, and we correlate it with SaO₂, the oxygen saturation. PaO₂ is the direct measurement of oxygen dissolved in plasma. SaO₂ shows how much hemoglobin is carrying oxygen.
Normal range, 80 to 100 mmHg on room air. PaO₂ below 80 mmHg indicates hypoxemia. Hypoxemia means the oxygen level in the blood is low. This is a critical finding. When you identify a low PaO₂, or hypoxemia, it is important to understand that there are different reasons why this might be happening. Clinically, we often think about hypoxemic respiratory failure in a few key categories. The most common types you will encounter are hypoventilation, V/Q mismatch, and shunt. Hypoventilation is perhaps the most straightforward cause. If a patient is not breathing enough, they are not moving enough air in and out of their lungs. This leads to a buildup of carbon dioxide and a corresponding drop in oxygen levels. The treatment is not just about giving oxygen, it is about restoring the patient's respiratory drive and rate. Another extremely common cause is a V/Q mismatch. In conditions like pneumonia, some parts of the lung may have good airflow, but poor blood flow, or vice versa. The good news is that hypoxemia from a VQ mismatch typically responds well to supplemental oxygen. Finally, we have a shunt. The hallmark of a shunt is refractory hypoxemia, meaning that the PaO₂ does not improve significantly even when you give the patient 100% oxygen. This is a very dangerous situation and often requires advanced therapies.
Now, let's bring all 4 steps together with a focused case. You are caring for a 65-year-old patient with a urinary tract infection who has suddenly become hypotensive, tachycardic, and confused. You suspect early sepsis. You obtain an ABG which shows pH 7.28, PaO 230, HCO 3-15, PaO 268. Step 1, the pH is 7.28, which is low. We have an acidosis. Step 2, we use Rome. The pH is low, and the HCO 3- is also low. They are moving in the same or equal direction. This points to a metabolic acidosis. Step 3, we use our tic-tac-toe grid. We have a value in each of the 3 columns. This is the classic pattern for a partially compensated metabolic acidosis. Step 4, we evaluate oxygenation. The PaO₂ is 68, indicating mild to moderate hypoxemia. Our complete diagnosis is a partially compensated metabolic acidosis with hypoxemia. Your priorities are clear: administer oxygen via nasal cannula, support blood pressure, give fluids and antibiotics, and continue to monitor the patient closely. Let's take on one more case. A 72-year-old male with a long history of severe COPD presents to the emergency department with increased shortness of breath. His ABG results are pH 7.29, PaO 268, HCO 3-31, PaO 252. Step 1. The pH is 7.29, which is low. This is an acidosis. Step 2. We use Rome. The pH is low. The PaCO₂ is very high. These are moving in opposite directions. Primary respiratory acidosis. Step 3. We build our tic-tac-toe grid. One value in each column. This shows a partially compensated respiratory acidosis. Step 4. Assess oxygenation. His PaO₂ is 52. Significant hypoxemia. Pro tip: be cautious with oxygen in chronic CO2 retainers. Apply it carefully. Start with a low-flow device like a Venturi mask. Aim for a target saturation of 88 to 92%. Full interpretation: acute on chronic, partially compensated respiratory acidosis with significant hypoxemia. Priorities are controlled oxygenation, bronchodilators, and possibly non-invasive ventilation. We have reached the end of our 20-minute journey, and you now possess a powerful, repeatable workflow for interpreting any arterial blood gas. This system is designed to replace panic with process. Your first action, always, is Step 1. Check the pH. Your second action is Step 2. Use the Rome mnemonic. Your third action is Step 3. Employ the tic-tac-toe grid. Finally, your fourth action is Step 4. Evaluate oxygenation by looking at the PaO₂. The final pro tip: the patient before the paper. Always treat the patient, not just the lab value. True mastery comes from practice. Your journey is just beginning. Find practice problems online, use case study books, run simulations with your colleagues and instructors. Each time you analyze values, you're building mental muscle memory. Walk into any room, receive any ABG, and know you have a system to decode it. Thank you for joining us on this journey. If this was helpful, subscribe to SkillTree Nursing. We make more calm, clear, clinical content to build your skills and confidence. Continue to practice, stay curious, and carry this new skill with you. You are now better prepared to face one of the most challenging aspects of patient care with calm assurance.